Welcome, everybody. This is Dr. Peterson from Whitehall. I'm Wes Warren, and today we're going to be talking about something that Dr. Peterson has come up with. One of the big problems with bringing on an associate is there's obviously a few problems with bringing on an associate, but one of the bigger ones is the dentistry that they see. I know we've compared notes on this before, but it's not uncommon that a new dentist, 4 or 5 years out of school or less, will typically see 1/3 of the amount of dentistry somebody that owns the practice will see. If the owner sees $10,000 worth of dentistry, the associate will see 3. If the owner sees 3,000, the associate will see 1. I mean, that is so common.
It's kind of scary.
It's scary. The other thing is when a doctor does a hygiene exam, and then 6 months later, a different doctor goes in and does an exam, and they see 2 different things. They diagnose, and they just scratch their head why the other doctor would diagnose it this way. And so you've come up with a system to kind of fix that. So go ahead, Doctor.
All right.
Tell us what you found.
Well, I agree with everything Wes just said. In fact, what really triggered me to put this together was one of my own clients who developed an illness, was out of the practice essentially for a couple of months, has an associate, it's been with him several years. The production in the office went down by almost 2/3 when the owner doctor was out.
Yeah.
Not just because he wasn't there, but the number of patients, it wasn't getting done.
Right.
So and the owner doctor had been doing the bulk of the exams prior to that.
Right.
So now we have the associate doing the exams, and the results are a nightmare. Production is dropped off a cliff.
Right.
So it made me think about the problem. The first step of scientific method is look at a problem and think about it. What's going on here?
Right.
And it took me back to the work I did with Western Regional Examining Board, which is a licensing examination body for many states in the country. At that time, it was 10 Western states when I worked with them. It's much larger than that even now. But as an examiner for over 12 years and a member of the board and actually president of the group, I was very intimately involved with the examination process.
Okay.
When we started making big changes in the exam process in the 90s, a lot of it was far too arbitrary prior to that time. And in today's world, you have to have everything that you do to be completely defensible, because you have to think, what would happen if this went to court?
Right.
And that was happening with a lot of the dental boards across the country. I know Texas was sued for discrimination because their exam wasn't anonymous enough, and that's what really drove them to the Western Regional Board. What we did was put together a team of experts to evaluate how we could come up with a valid and reliable licensing exam. And those 2 terms aren't just arbitrary terms. They have a definite meaning in the world of examining. Valid means the exam tests for what it's supposed to test for.
Mm-hmm.
And reliable means if you test a large group, it's going to give you reliable results over that group.
Right.
So those are true testing terms in high stakes testing. So we put together a team of educators, some of the deans from some of the schools, and through Arizona State University, we met with members of the Department of Educational Psychology that were experts in psychometrics. And psychometrics is the science of constructing, evaluating, and validating examinations. So they worked with us very closely in developing clinically based exams that had not been done before.
Okay.
That were valid and reliable. It took us a number of years. The things that we found out essentially boil down to this. If you have good, valid criteria for what you're testing for, And in our case, it was often preparation design, fit and contours of restorations, things like that. If you have set criteria for all of those items and then train your examiners in those items and grade them typically on a scale of 1 through 5. If you have that and you get the consistency you need, you have a very valid and reliable examination. And we proved that over and over. After every examination, there was a full psychometric evaluation of the results, so we knew they were solid. So having done that in the past,
You put one together.
Hey, why don't we use all this information and see what we can do for this problem, which is essentially an examination problem.
Right.
So that's the background on it. So you could make this as complex or as simple as you want. I always go for simple.
Right.
So just very briefly on the first slide, this is the protocol. This is essentially how you'd start a paper if you were doing a scientific paper. The background is pretty much what I just talked about with the doctors not being consistent. In the process of treating patients in your office, a lot of your credibility goes back to the consistency that people see in your office. If your doctors are seeing wildly different things when they do an exam, and your hygienists, frankly, also, they should be
Calibrated as well.
Absolutely, they should be calibrated too, because any inconsistency is seen as a significant negative. So that's the background, these problems. The purpose is to try to determine how consistently we can get people to see the same thing, because it just expands from there. If you see the same things, then, and you find that your, let's say 4 doctors all are seeing pretty much the same thing, but the end result is different, then their treatment planning is incorrect, and you have to work with that. So this is the first step in making sure people see the same thing and then develop the same treatment plan. It's a great learning experience. Here's what we recommend. A number of patients should be approached, and this can vary with office, and asked to participate in the in-office study on the consistency of doctor examinations. The process needs to be described to the patient fully, and I would recommend giving them some kind of an incentive because they're going to be spending a couple hours.
Of course, yeah, right.
What you give is up to you. You must get written consent. Anytime you treat a patient for anything, even in these types of purposes, get a consent form. This is not a university-based protocol, and it doesn't have to go through a human exam or a human research committee. I can tell you from experience, sometimes submitting a proposed study using human subjects would take 6 months just to get approved through the university committee. So thank goodness we don't have to do this.
Yeah, right.
We're doing that on our own. So each patient will then receive a clinical examination using the criteria.
How many patients would you recommend they line up, try to get lined up to do this?
1 or 2 to begin with.
Oh, okay, so not.
No, you don't have to do 6 or 8 or 10.
Right, okay.
We have one office that has already done 1 patient, and they're going to do at least 1 or 2 more, and I can go through what they're finding so far. We're just going to look really for 3 different things. We're going to look for caries decay. We're going to look for cracks and fractures, and then we'll look at the existing dentistry. All 32 teeth will be examined and graded on a scale through 1 through 5. So the next slide is what those numbers mean. This is how you'll grade them. And in decay, under the red, a 1 will mean there's none or little staining. 2, incipient or early decay. 3, dentinal involvement. So we've broken through the enamel junction with the dentin. And 4, significant dentin involvement. And 5, probable pulpal involvement. So that's the scale. Those should all be things that dentists are fairly familiar with. And what we did actually with our test was when we had examiners come in, we would go through a review of pictures of the scales of the exams, what they'd be examining for, and test them on it.
To make sure they're,
to make sure they're consistent.
okay,
And if we went through the exam and the test and they failed, we would do it again. And if they failed it again, we'd do it a third time. And if they failed it the third time, they're out. We send them home.
right.
Send them home because you can't have rogue
They're
examiners.
too far off the,
Yep. So what we're looking for on all these is results that are within ideally just one number. At 2, we better start looking seriously at what's going on.
okay, so let's just go through this. So
All
if
right.
there, somebody puts a 4 down and the next doctor puts a 2 down, you're saying that that's a problem. If they put a 3 or a 5 down, okay, it's close.
Maybe I would say if they're not just within one number,
One number.
then we better look at it.
Okay.
Because with a scale of 5, 2 numbers off is significant.
Yeah.
So second one, cracks and fractures. Again, nothing or minor crazing. 2 light cracks to enamel. Now you can see if somebody called something a 1 on cracks and fractures, someone else called it a 2. Not that big a deal.
Right.
But
If somebody says a 1
and somebody
it
says
says a 3,
a 3 or a 4,
that's a big deal.
it's a bigger deal because with the 3, it's obvious the fracture goes through the enamel.
Right.
4, it's deep into the dentin, and 5, it may well involve the pulp.
Right.
So if you've got more than a 1 number variation, that's a stenine too far.
Okay.
Existing dentistry, again, this is an evaluation based on what you see. 1 would be good, functions okay, good contours, everything looks all right. Number 2, functional, but there's some problems. Maybe there's a contact, maybe there's a slight overhang, maybe there's the occlusion not quite ideal, but it's not significant or not serious, let's put it that way.
Right. Okay.
3, we get into real problems, marginal voids, you can stick instruments, more than just a little catch, this is deeper. 4, major problems, significant fit and function problems. And then the final would be a failing restoration where you may have caries and you may have a lot of other
Right.
difficulties, wear spots that have gone through, that sort of thing. So these were the 3 criteria we looked at. Now, these are basic. We're not getting into anything real sophisticated. We're not doing TMD evaluations or full occlusal analysis. We're looking for the basic stuff here.
Right.
Now, after all the doctors have examined each patient, then have them create a treatment plan based on their findings, and then discuss your individual findings to see where the variations are. And this is where you can get into some real learning experiences.
Yeah.
So the last page I have on this is the actual grade sheet, basic grade sheet, so it doesn't take too much time. Teeth 1 through 32 on the left-hand column, then the decay and caries, the cracks, fractures, and the existing dentistry, so our 3 categories, and then a scoring cheat sheet on the right side. With an assistant, this should go fairly quickly. You could go tooth by tooth and give your grades for each of the teeth, and then move on. When you're finished, it's not a sophisticated analysis, you know.
You're just looking for those,
you're looking for
those differences, those variations, and then going back and discussing them.
As they say in statistics, figures can lie and liars can figure. But so we're not doing serious statistical evaluation. What we're looking at is consistencies and inconsistencies.
Yeah. Okay.
This is something new. I did not take it through a lot of beta testing. I put it together. We discussed it and decided to introduce it.
Well, I think it's way better than what most people do.
Yes.
Most people don't do anything.
You know,
Very little.
the typical calibration in a lot of offices, if they do one, is to show a few slides and say, what do you think? And there's a place for that.
Right.
But to evaluate anything, you've got to know your numbers. Just like in business, to know your business, you have to know your numbers. To know what you're looking at and to compare, you've got to put numbers to it so then you can evaluate it. So we have a couple of offices that have started this process after we introduced it at a mastermind a few months ago. The first office that did it, 3 doctors, owner doctor, 2 associates. One of the associates is around 50, and the other associate is second year out of a general practice residency. And they found it was an excellent learning experience. They said
I can imagine.
in most cases, they were not more than one number apart. It was uncommon for them to be two numbers apart, which is good.
Yeah.
However, it opened up a lot of discussion about what is the appropriate treatment plan.
Yeah, okay.
So that is a whole second discussion. So if your team, your people, your hygienists, your doctors are seeing pretty much the same thing, then you got to talk about what's the appropriate treatment.
What are you running into? Where they get snags on which ones they think is important to start, which one, or how they would deal with it?
How they would deal with it.
So
yeah, is this
a crown, or
is this a crown or a 2-surface restoration, maybe a 3,
right,
or a 3 maybe ending with buccal and lingual extensions, and you know, you can go crazy on that stuff.
right.
So appropriate treatment planning, again, consistency. You know, and Dr. Sayer said something at our last meeting, which I thought was very consistent, or very interesting and enlightening. And he said that they work so hard on this type of a project, more with slides, that there's very little difference in the treatment plans that their doctors present. And I don't think too many offices can say that, especially when they have young, new doctors.
I would agree.
So this is a system that can be put in that allows you to see what people are seeing. And then once that is done, once you're consistent
And you
with
talk
what you
about the
see,
treatment plan.
go to treatment plan. Right,
How would you
exactly.
deal with these teeth? When does it? I think that this obviously is very important, but I think also doing this with your hygienist so that they all get calibrated. Obviously, if a hygienist has been working with you for years, they kind of self-calibrate because
You're right, they do.
you know, but a doctor doesn't work with you.
Correct.
I don't walk around and follow you with your patients, maybe the first week.
Not on a regular basis.
Right, but the hygienist is going to see it over and over and over again.
Yeah.
And so they get calibrated just through time. But an associate is not, and a new hygienist is not.
I'll also tell you, I've had hygienists tell me when there's multiple doctors, they will, if they think a tooth needs a crown, the hygienist. Now,
Okay.
granted, I get it, they can't diagnose.
Sure.
We all know that, but they're not stupid. They know what they're looking
Yeah, right.
at. And they know which doctor is going to say crown and which one is going to say watch it and which one is going to say
Fill it.
restoration.
Yeah, right.
And they will call the doctor that they know will go with the treatment that they think is the best.
Interesting.
So, and that's really kind of scary.
That is a little scary, yeah.
Because not from the fact that the hygienist has an opinion, because they should have an opinion.
Sure.
They know what they're looking at. But the fact that they're actually deciding who they want to call based on what treatment they know is going to be
That's pretty
presented.
wild, yeah.
That is kind of a bridge a little far. However, I get it.
You put together this protocol and you test on a few patients and try to get calibrated and really have those discussions on how you would treatment plan these things.
That's the next step.
And then you should do this periodically for a good 6 months, I would guess.
I would say, in fact, it's just a good idea to actually have interactions with your colleagues.
Yeah.